So I'm starting with the live now. Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Clarnet, serving as a designated session assistant to ensure a smooth and seamless experience throughout the event. Clarnet proudly stands as India's most trusted digital platform offering a wide range of enriching services exclusively for the doctors. It is indeed an honor for us to serve as digital partner for this esteemed event. The central focus of today's session is Onco Anaesthesia. Now, I would like to invite Dr.AL.Meenakshi Sundaram, sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former national vice president of the Indian Society of Anesthesiologists and has held key positions including governing council member, president and state secretary of the IAC Tamil Nadu state branch. So without any much further delay, sir, you can proceed, sir. Over to you.
Thanks, Clarnat, for the opening remarks. I welcome you all for the 51st webinar of Puthukkottai Bhudhan, second edition. The 50th edition of Puthukkottai Bhudhan, second edition, was held on 31/12/2025, and the theme was medical documentation. The faculty were Dr. Madhu, postgraduate from Bangalore Medical College and Research Institute, Dr. Asha and Dr. Nazia Bano, both are assistant professors from Bangalore Medical College and Research Institute, and it was moderated by Dr. Dayanand, professor, Bangalore Medical College and Research Institute. And 953 delegates attended the program live. And with that, 51st webinar we are coming. It is a penultimate webinar. At the outset, I want to inform the valedictory webinar of Puthukkottai Bhudhan second edition will be the next week, that is January 14th, Makara Sankranti, and it will be dedicated to ISA because the first edition also, we have dedicated it to the ISA, last valedictory webinar. Same way, it will also be dedicated to ISA. So the ISA will hold that 52nd webinar to expose their activities. And today, the youngest faculty will be Dr. Shwetha Desai, and she has done, she is originally from Karnataka. Today only we came to know that she is from Karnataka, and she has done her MBBS from Nijalingappa Institute, and she has finished her MD from AIMS Bhubaneswar. And now she is doing a DM Onco Anesthesia, DM Onco Anesthesia in as a postgraduate, super specialty postgraduate in AIMS New Delhi, and he has won. And we welcome Dr.Apeksh Patwa because he is a so busy person, but he has kindly consented to present his face in the Puthukkottai Bhudhan webinar. So please. And Dr. Shwetha won the first place in quiz competition in ISACON. And she has won the third place in quiz competition in the critical care conference to East Zone. So if it is anesthesia, she will be number 1. And in critical care, she will be number 3. And she is interested in reading. Reading means not anesthesia text. She is maybe interested in reading novels and all. And she is interested in traveling. At the time, we will say you are roaming here and there. Now people are saying we are traveling. We are interested in traveling. That is a reputation of saying instead of roaming, we say we are traveling. And the best part of Dr. Shwetha, see this ever smiling doctor with a childish face is yet to be married. So she is a eligible bachelor, and Puthukkottai Bhudhan will sometimes it will act as a matrimonial service. So minimum 900 people will be attending, and they will take the message forward. She is originally from Karnataka. Now she is a postgraduate in AIMS New Delhi. That introduction is enough for her. And next is going to be Dr. Pratishtha Yadav, another doctor. She got her marriage fixed, and her fiancé is a nephrologist. So that part is over for her. And she is a MD and Dip B graduate. Usually we say Dip B is tougher than regular MD anesthesia examination because the internal examiner will be very kind to the MD postgraduates. But she has done Dip B also, that is a woman power. So she is a qualified DM onco anesthesiologist and she is interested in one lung ventilation, which Dr.Apeksh Patwa will also do. And she is interested in pediatric anesthesia and palliative medicine because she is interested in onco anesthesia. She is interested in palliative medicine. And see, her achievements are many. She has won the first prize in the podium presentation. Presentation of SOAP Critical Care Conference. So that means she is good in communication. It is not a poster presentation. And if it is a poster presentation, she is winning only the third prize. So first prize in podium presentation and the third prize in the poster presentation. That means she is an emerging star. So surely in future she will be a superstar to reach the status of Dr. Apeksh and Dr. Namarata, and she is interested in photography. Usually females will be less interested in photography, but she is interested in photography and reading. And if I ask you what are your hobbies, she will say gardening. I don't know how she will be interested in gardening because she is winning first prize and third prize in many competitions. She may not have enough time. Probably gardening means she will see the garden while coming inside the house and while going out. I think she will see the garden. That is gardening. Anyway, we will take it up as she is interested in gardening. And that next speaker is, internationally is a popular star. And Dr. Pratishtha Yadav and Shwetha should be happy to share the dais with Dr. Namarata and Dr. Apeksh Patwa. Apeksh Patwa is a chief consultant in Kailash Care Hospital, Muni Ashram, Goraj. And he is a chief consultant in Vadodara Institute of Neurological Sciences in Vadodara. And Adicura Super Speciality Hospital also, she is a chief consultant in Vadodara. And this man has dedicated his life to airway. So I think first he has married to trachea, then he has entered into that other part of life. So he has dedicated his life to trachea, and so he is always in All India Difficult Airway Society. So all algorithm, everything. So I am not seeing any difficult airway in my anesthesia practice because I am reading what Apeksh Patwa writes. So that is the easy way of negotiating the difficult airway. And he is a co-author in many difficult airway chapters. For 2016 and 2025, he has written an article in IJA, and he is a ISA Academic Excellence Award winner in 2017. So what I want to convey, it is not to project Apeksh Patwa, it is to project Puthukkottai Bhudhan. We select candidates who are expert in that field. See, the onco anesthesia people are talking about onco surgeries, and this airway man is going to talk about airway management. And Dr. Namarata madam, who is having more years of experience in onco anesthesia, is going to moderate. So we want to project Puthukkottai Bhudhan. In addition, we projected Dr. Apeksh Patwa also. So he is a winner and he is a course director in All India Difficult Airway Society Fellowship in Muni Ashram, and he is a past General Secretary of All India Difficult Airway Society, and he is a faculty in all national airway conferences and international conferences, and he has delivered only 300 lectures across the country. So only 300. So probably if we add everything, it may amount to 3,000. Wherever you see him, he will be only with the airway, and just because he cannot have a human airway, he is always seen with a goat's airway. So always he will be having one trachea and two lungs. So it is handy for him. It is handy. Just like Lord Muruga is having a spear, he will be having one trachea and two lung always. Probably he may be having it in the left hand. We have to check. And he is the inventor, Patwa Shah eye video laryngoscope. He is the inventor, original inventor. And another one, this HFNO device, HUFIO2, that is also invented by him. Again, everything is airway and ventilation only. So naturally, he is going to talk about airway today. And he has won 3 national awards. And he has 26 national publications to his credit. So Dr. Pratishtha and Dr. Shwetha to follow him in presentations, and he has written 10 book chapters. So Puthukkottai Bhudhan is very happy to welcome Dr. Apeksh Patwa for this penultimate webinar of the 2nd edition. And when these stalwarts are there, we want a good moderator so that these people can be taken to task. So we have fixed up Dr.Namarata Ranganath from Bangalore. So she is originally from Rajasthan. She is originally from Rajasthan and settled in Bangalore. So Madam has exposed to all the states in across the country, but one brought up and another one settlement point. And Madam is a professor and a former head in Kidwai Institute of Oncology. See, she has more than 30 years of experience in onco anesthesiology. Again, Puthukkottai Bhudhan is proud in welcoming Dr. Namarata Ranganath because she is the eligible moderator to moderate this session. And she is interested in head and neck onco anesthesia. She is interested in thoracic anesthesia also. So, Madam is presently the president, Society of Onco Anesthesia and Perioperative Care. So, it is natural that she presides over the webinar today. And if out of all these achievements, she is a good runner. You can see her physique. So, she is a good runner. But whenever there is a crisis, she will immediately reach the spot because she will be coming like a sprinter. So, she will not run away from the scene. She will run towards the scene. So that is a good personality of Dr. Namarata. And she is interested in sketching. And Dr. Pratishtha may be thinking that she is interested in photography. But I want to tell her Dr. Namarata is a senior photographer. She is also interested in photography. So necessarily you have to follow her. And I request these 2 candidates to follow Dr. Namarata and Dr. Apeksh Patwa, who are senior in their profession, and you have to utilize their expertise. And now I request all the delegates to utilize this opportunity to listen to the top faculties. Thank you very much. And over to Dr. Namarata, ma'am.
Thank you so much, sir, for introduction of all of us in such a good way. And let's start the webinar. And I think the first speaker will be Dr. Shwetha.
Yes,
over to you, Dr.
Shwetha. Thank you for the introduction, sir. I'll be starting my seminar on pre-anesthesia evaluation of patients receiving systemic anti-cancer therapy. A wide range of treatment options are available for patients receiving anti-cancer therapy. As an onco anesthesiologist, we encounter such patients either in the perioperative or critical care setting. Hence, it is essential to have a comprehensive understanding of these treatment modalities and the wide range of effect they have on the human body. The basic terminologies we should know before we start into onco anesthesia. Neoadjuvant chemoradiotherapy, which refers to the treatment that is administered before a definitive surgical intervention of primary tumor, metastasis, or both, with the aim to improve the chance of complete surgical resection and survival, or reducing the need for a more complex surgery. Adjuvant chemotherapy refers to the therapy that is administered after the removal of the tumor mass, aimed at managing micrometastasis and thus reducing the risk of tumor recurrence. Palliative chemo or radiotherapy is given not with an aim to cure the cancer, but it is aimed at improving the quality of life due to the debilitating symptoms. These are either given as an induction therapy for complete remission or consolidation, where a repetition of the drug at a lower dose is given in a patient who's already achieved remission, or as a maintenance therapy to prevent recurrence. The basic difference between these medical options are that chemotherapy acts on the targets with rapidly dividing cells, mostly cancerous cells, but it can also affect the normal cells of the intestine and other rapidly dividing cells in the human body. Targeted therapy aims to targets the cancerous genes that are present in the body, genes and proteins that are present, and inhibits its growth. And immunotherapy aims to use the immune system against the cancer. These are the most common drugs that we come across in our perioperative settings. Chemotherapy agents like alkylating agents, antimetabolites, microtubule damaging agents, topoisomerase inhibitors, antibiotics, and other miscellaneous drugs like retinoid, hydroxyurea, etc. Targeted therapy is a newer agent. These are newer agents that are that are being more commonly used in our settings. Tyrosine. The examples are tyrosine kinase inhibitors like imatinib, dasatinib, nilotinib, HER2 receptor inhibitors like trastuzumab, sunitinib, sorafenib, etc., bortezomib, rituximab, and everolimus. And immune checkpoint inhibitors are a class under immunotherapy. I will just be covering these because the immunotherapy is a wide spectrum of agents that is available. The most common drugs we come across are nivolumab, pembrolizumab, atezolizumab, and ipilimumab. It is imperative that we know the common side effect of these drugs during our pre-anesthetic checkup, as the eyes will not know what the mind doesn't already know. The most common risk factors for cardiovascular side effects in these set of patients would be prior anthracycline-based treatment, elderly or very young age group of patients, prior mediastinal or chest radiotherapy, hypertensive, pre-existing diabetes, previous combined therapy with trastuzumab and anthracycline, elevated cardio biomarkers, or pre-existing LV dysfunction before the induction of cancer anti-cancer therapy. This dysfunction manifests as either type 1 or type 2 dysfunction. Type 1 is an irreversible myocyte damage caused due to myocyte apoptosis, which is usually dose-dependent, progressive, and can cause permanent cardiovascular damage. It is usually caused by anthracycline group of drugs. The second kind of dysfunction is caused due to mitochondrial alterations by drugs like trastuzumab. It is usually not dose dependent and it is reversible with drug discontinuation. So it is unlikely to cause long-term damage. The 4 phases of cardiotoxicity are LV dysfunction. This is the most dreaded complication and the most common one that we see. It is caused by groups by like anthracycline, trastuzumab, taxanes, etc. The other phase that we see is the myocardial ischemia and acute coronary syndrome that is caused either by coronary vasospasm, thrombosis, or arteritis because of the inflammation caused by these agents. This can present as angina or myocardial infarction with ECG changes and elevation in cardiac markers, usually caused by drugs like fluorouracil, paclitaxel, etc. Coming to the other side effects that we see, that is hypertension, which is due to VEGF inhibitors that is caused by alterations in the nitric oxide balance, and QT prolongation caused by drugs like arsenic trioxide, tyrosine kinase inhibitors, etc. So in our clinical present evaluation, we need to look for the take a complete history, look at the ECG for arrhythmias, conduction abnormalities, and QTC. In the transthoracic echo, we need to look at the LV ejection fraction along with the global longitudinal strain, which is a very sensitive marker for the early detection of myocardial toxicity. And there can be elevated biomarkers like troponins and anti-proBNP. We also need to look at the metabolic panel and actively manage any modifiable risk factors. The pulmonary side effects that are available that are seen are usually caused by drugs like busulfan, cyclophosphamide, bleomycin, methotrexate, taxanes, etc. They present as interstitial pneumonitis, ILD, pulmonary fibrosis, which can progress to ARDS, non-cardiogenic pulmonary edema, pleuritis, acute bronchospasm, thrombotic microangiopathy, etc. The most notorious drug known for causing pulmonary toxicity is bleomycin, with an incidence of up to 40%, which is seen 4 to 10 weeks post-therapy. Risk factors include old age, a dose more than 450 units, concurrent RTCT, uremia, low pulmonary reserve, oxygen therapy, etc. It is usually caused because of the metaplasia of type 1 pneumocytes into type 2, which can become irreversible, and also the injury caused by reactive superoxide species, which can all lead to fibrosis in the end. It presents as non-cardiogenic pulmonary edema, pulmonary fibrosis, hypersensitivity, pneumonitis, interstitial lung disease, etc. On imaging, we can see perihilar infiltrates, which is seen usually at the bases. PFT reveals a restrictive lung disease kind of pattern, and a DLCO decline of 10 to 15% from the baseline is considered significant and has significant perioperative mortality. The main thing that we have to know about bleomycin is we need to titrate our FiO2 during surgeries to target a SpO2 of 88 to 92% to avoid oxygen-mediated free radical injury. Cisplatin is the most common drug that is causing AKI with the incidence of 30%, and this is the dose limiting factor of the drug also. Other drugs like ifosfamide, methotrexate, mitomycin, cyclophosphamide can also cause it, and these present as acute tubular necrosis, or it can also cause prerenal AKI due to vasoconstriction, microangiopathic hemolytic anemia, hemorrhagic cystitis, nephritis caused by immune checkpoint inhibitors, etc. The CNS complications can manifest as either central or peripheral neuropathy with a myriad of symptoms like encephalopathy, press, meningitis, etc. The peripheral neuropathy usually has a glove and stocking distribution, and it progresses proximally. It usually presents with autonomic dysfunction, so we always need to look for symptoms of autonomic dysfunction in patients with peripheral neuropathy. Vinca alkaloids are the most common drugs causing it, along with cisplatin and other platinum-based compounds. GI toxicity is mostly the most common side effect that is seen with chemotherapy agents, which manifests with nausea, vomiting, diarrhea, mucositis, and can cause fluid and electrolyte abnormalities. Oral mucositis causes airway edema and bleeding risk, which predisposes to a difficult airway, especially in its acute phase. Patients presenting with chemo-induced nausea, vomiting need to be induced with rapid sequence intubation. Most of these drugs undergo hepatic metabolism, and hence they can cause a different kind of injuries like hepatic sinusoidal injuries, centrilobular necrosis, steatosis, transaminitis, etc., which can manifest as deranged LFT with transaminitis and hyperbilirubinemia, deranged INR, which can cause postoperative liver dysfunction. Coming to the hematological complications, this is the second most common side effect seen with all class of drugs, which can present either in single or together as pancytopenia. And hence, we need for a bone marrow recovery of at least 6 weeks before boosting these patients for surgery post-chemotherapy. To summarize, these are the immunotherapy-related side effects with endocrine. The most important side effects for immunotherapy drugs are hypophysitis, thyroiditis, adrenal insufficiency, and type 1 diabetes. Cardiovascular manifestations like myocarditis and pericarditis can also be seen. Targeted therapy, this is a summary of the targeted therapy side effects. Coming to the radiotherapy, this can cause the mechanism by which it works is it causes DNA damage, cell apoptosis, and releases alarmins, which activates the body's adaptive and innate immunity against the cancer cells. It is given as external beam radiotherapy, brachytherapy via body catheters, or stereotactic RT. It can manifest via in a lot of ways like premature CAD, restrictive cardiomyopathy, valvular lesions, conduction abnormalities, pericarditis, or effusion. It can cause pneumonitis, which can progress to fibrosis and cause subsequent damage to the lung. The important side effect would be the airway-related changes, that is mucositis and edema, which later progresses to fibrosis, which can lead to xerostomia, soft tissue fibrosis of the neck, reducing the mobility, tracheal fibrosis or stenosis, osteonecrosis of the mandible. GI side effects like diarrhea, malabsorption, hepatic injury, and veno-occlusive disease in the liver, and nephropathy, hypertension, dysuria, fibrosis of the bladder can also manifest. Skin and subcutaneous tissue, erythema, desquamation, contractures can also present with neurological manifestations like transverse myelitis, myelopathy, and plexopathy can also happen. Hypothyroidism and adrenal insufficiency can happen in head and neck arteries, and fractures can also occur during radiotherapy. So as onco anesthesiologists, we need to tailor our evaluation based on the therapies that the patient have already received. Thank you.
Thank you, Shweta. In a very short span of time, you have covered so much. And this is very, very important for non-onco anesthesiologists equally to know these, because as you said, what you don't know, you will not see. So coming to the second speaker, Dr. Pratishtha, she would be speaking on perioperative management of patients receiving cancer therapy. Over to you, Pratishtha.
Thank you, ma'am, and thank you, Shweta, for making my work job easy. So now, without wasting time, we'll start. So my topic will be perioperative management of patient receiving cancer therapy. As we know, the cancer is the second leading cause of death worldwide. The incidence of new cancer cases was around 14 million in 2022 and 2012, and it is expected to reach about 24 million in 2035. The mainstay of management is for especially for the solid organ tumors is a surgical resection, and the remnant cancer cells following surgery are subjected to chemotherapy and radiotherapy, or it can be other way around also, like giving chemo and radiotherapy to shrink the tumor so that can easily be resectable. Apart from that, the recurrence following the surgical resection is also is there, which varies dramatically and is influenced by many factors, including the primary organ affected, tumor grade, and the stage. If we compared giving anesthesia to the non-onco patient and onco patients, there are very important points that are there that need to be considered. As discussed in the previous lecture by Dr. Shweta, that the cancer therapy can have widespread side effects, and as an anesthetist, we must know it can be from hematological and it can range from all the system, from cardiac system or in lungs and renal system. All that any of the system can be affected, and as an anesthesiologist, we must be aware of them. Then, from airway and respiratory point of view, some head and neck tumors can actually make our laryngoscopy and intubation quite difficult. Any tumor in the buccal mucosa or tongue, that will be more detailed. In the details will be discussed in the next lecture. And apart from that, any mediastinal mass like any large thymomas or any large mediastinal lymph nodes can compress the intrathoracic part of the airways. The patient may appear normal and breathing normally during the awake state, but once we give anesthesia, administer anesthesia, patient is anesthetized and is relaxed, this mass can severely compromise the airway. And we need to take proper measures while dealing with these patients. Apart from them, lung masses, lung tumors itself or any other cancers like osteosarcoma may present with lung metastasis, and they may come to us for metastectomy surgeries. So we need to keep in mind while dealing with these patients also. Then cardiovascular concerns, apart from chemo-induced toxicity, there can be some cases of autonomic dysfunction has also been reported using the chemotherapy. We should be aware of them. Then after the chemotherapy and radiotherapy, patient can be immunosuppressed and they may be more prone to infections. So we need to maintain good sterility while dealing with invasive lines or dealing with these patients. And another important aspect is immunomodulation that I will be covering in coming few slides. Then drug interaction we must be aware of. As these surgeries are very extensive and long surgeries, the pain management and regional anesthesia holds a very important role to make the patient recovery easy and quicker. Then there are specific procedures like hyperthermic intraperitoneal chemotherapies, then robotics, then one lung ventilation. These are the special things that we have to consider while dealing with onco patients. So as discussed, following the surgery, variety of mechanisms can lead to cancer recurrence. It can be either local cancer recurrence at the primary site, or it can be lymph node, or it can be distant organ metastasis, or seeding into the body cavities, like while doing a ovarian cancer resection, they can be a seeding of cancers in the peritoneum. So these are the various mechanisms of cancer recurrence. As we see here, the primary tumor is vascular because it has its own niche for the survival and propagation. These cancer cells may dislodge into the lymphatics and the vessels, may embolize, reach the heart, and circulate it throughout the body. They may
rest in organs like lung or liver, where they may adhere to vessel wall, extravasate, and form its own microenvironment and proliferate with angiogenesis and survive and form a metastasis that can appear many years later, even despite of the primary section. But the immunity of the body itself can identify and eliminate some cancer cells, and that is called as immunosurveillance. And it is mainly delivered by NK cells and cytotoxic CD8 plus T cells. But after the surgery, initially because of the damage and the injury, there is a pro-inflammatory phase, which is often followed by a period of immunosuppression. So, and why should we be aware of this? Because a lot of what we do in the perioperative period and intraoperative period can have an effect on this immunosuppression. And in this immunosuppression can actually have a negative impact and can help in survival of these cancer cells. This can be influenced by activation of the sympathetic nervous system, HPA axis, then increasing circulatory inflammatory mediators. Some of the very common problems during the anesthesia, like hypothermia, and some of the anesthetic agents have been associated with increase in the immunosuppression. If we see here, during the tumor excision, there is a circulating tumor cells that enter the blood vessels and reach the distant tissues. If we see here, due to the immune cell activation, as I said, it's a pro-inflammatory followed by immunosuppression. The release of number of factors like IL-6, COX-2, MMP2, and 9, all these lead to the inflammatory cancer stimulus that can increase the motility, invasion, and proliferation of cancer cells. Then local tissue hypoxia can lead to increase in the HIF-1 alpha and VEGF-1 that helps in supporting angiogenesis that will provide new vessels to these cancer cells and help in survival of these cells. Then any pain stimulus can activate the HPA axis, increase the cortisol levels, and in turn lead to immunosuppression that will decrease the activity of NK cells and all the immunomodulation and the protective immune system can be hampered and ultimately lead to the survival of these cancer cells and lead to metastatic growth. So there is often a struggle between the cancer cells and the human immune system, and that is actually controlled by inherent properties of cancer cells, and on the other hand, the ability of body to contain them, or called as resilience. So as discussed, these are the local tissue injury factors, increased inflammatory tissue edema, and colonization. Apart from them, I will like to focus on this part, that is the pain, anxiety, hypothermia, any metabolic disturbances, even the blood product transfusion can lead to systemic effects that can lead to immunosuppression and increase the survival of these cancer cells, leading to dormant or growing micrometastasis that can appear in after few years and lead to the recurrence. So, as discussed, various anesthetic agents have been found, especially in vitro. As here it says that in vitro they have found to support some of the common pathway for the survival of cancer cells. Like as we saw in the flow chart, that volatile agents can increase the HIF-1 factor and insulin growth factor that help in cell proliferation and angiogenesis. On the other hand, we see here there is a propofol that decreases it. So it is actually helping in decreasing the survival of these cancer cells. Similarly, local anesthetic agents have found to have a negative impact on epidural growth factors and nuclear factor kappa B. And on the other hand, the most common in the news and all the studies in the recent past years, like related to opioids, have been found to support vascular endothelial growth factors, NET1, that supports the cancer invasion and angiogenesis. So what we see here is some might be acting as a friend and some might be acting as a foe. But we should remember that despite of lab in vitro findings that have shown that the effect of numerous anesthetic agents on cancer cells, however, these results have not been easily translated into clinical settings, as most of the studies that have shown are actually retrospective and have are of not very significance. So we look forward to more prospective studies and to see actual with a good strength studies, so we can actually find which techniques are safer for the oncology. So despite hope from early retrospective studies, the use of regional anesthesia in cancer surgery has not been associated with any significant decrease in either recurrence or survival in several randomized controlled trials. As we saw, the local anesthetics and the regional anesthesia with control of pain can reduce the sympathetic nervous system activation and decrease the cortisol level, but still these have not been shown to have a clinically significant effect. And apart from their lab and retrospective studies have actually supported propofol-based intravenous anesthesia as compared to volatile anesthetics. But there is, as I said, insufficient evidence to support or to go against any specific kind of anesthetic agent or technique. So as an anesthetist, we should remember that our role is not just to create awareness and administration of anesthesia, rather, and it is an opportunity to minimize the biological perturbations of surgical stress response and to adjust the anesthetic techniques to minimize the activation of cancer progression pathways by minimizing the impact of surgical trauma and to maintain the integrity of the immune system. So next important part is the prehabilitation, rehabilitation, and the survivorship of the patient. If we go to the definition point of view, rehabilitation is actually it's a healthcare services that help a person to get back or improve skills and functioning of daily living that have been lost or impaired. That is already the person has been hurt or sick or disabled. But now we are coming up to a new for many years, the concept of prehabilitation has taken over the rehabilitation. It is actually a time-based definition, and it involves assessment and intervention that are initiated prior to the start of acute cancer treatment. That is, we do the intervention and strengthen the functional capacity and work in the favor of the patient before any treatment has begun and before the actual significant functional capacity is reduced. These patients, especially when we come across oncology patients, these patients, because of the pre-existing medical condition, already reduced functional capacity either due to nutrition, and these patients have a significant weight loss prior to we find them, they present usually with a significant weight loss, then their physical capacity is reduced, plus there's a psychological status, they are mostly depressed or anxious, and they are undergoing various pharmacological and procedural interventions that reduces their functional reserve. And these may have cancer-related anemia, then the anxiety, depression, all ultimately lead to the decreased functional fitness deconditioning. So to address these, there is a concept of rehabilitation can help. And in the coming slides, we'll go through step by step. First is the great emphasis has been given to the preoperative exercise programs. In our setup, whenever the patient comes to us, we make sure that the patient has gone to a prehabilitation clinic. They are undergoing various exercises. Various studies and various protocols have said that we should focus on cardiovascular, muscular fitness, as well as targeted exercises, focusing on the training specific muscles. But if you look at it, it has been found that it increases the lean body mass to body fat ratio, decreases the insulin resistance, decreases the prostaglandin synthesis, and also helps in skeletal muscle adaptation. And it has been found that it also decreases the side effects of the cancer treatment, like chemotherapy. Apart from that, if you look into the specific cancer types, like giving incentive spirometry to the patient who are doing major abdominal surgery and thoracic surgeries, the compliance is much better and they are trained better. And in the post-operative period, these exercises, they are able to perform better with a better recovery. Similarly, any head and neck cancer, the deglutation exercises or pelvic floor exercises in the prostate cancer can be trained beforehand, before the surgery takes place. The second important and very controversial topic is hematinic optimization. These patients are often in a need of transfusions, but why? It can be due to tumor biology, like these may be hematological malignancies with bone marrow suppression. These some chemo and radiation and immunotherapies can cause bone marrow suppression, leading to anemia or decreased platelet count. Then anatomical features like any tumor that is near to the vascular structures are potentially at a high risk of bleeding. Then any GI cancer, colon cancers often present with melena or hematemesis. Then complexity of resection, extensive resection, cytoreductive surgeries are often associated with large fluid shifts, a lot of blood loss. Apart from that, when we are managing these patients, hemodilution, hypothermia, metabolic derangement can further increase the risk of bleeding in these patients. especially the esophageal and the stomach cancer, patient can have vomiting and poor appetite, along with nutritional deficiencies like iron, folic acid, and vitamin B12, ultimately leading to anemia. Then some of the cancer can also at a risk of DIC, and liver metastasis or GB mass, big GB mass, can cause liver dysfunction, leading to the deficiency of clotting factors. So these are the different reasons why these patients are often in a need of transfusion that we need to address. There's also a cancer-related anemia seen in these malignant patients. It is often due to ineffective erythropoiesis, due to hemolysis, or blood loss also. But transfusing blood and blood products is not easy and straightforward in these patients. As we discussed in the previous initial slides, that there is an immunomodulation. That is, when these perioperative blood transfusion are done, there is a release of cytokines, RBC-derived microparticles, and growth factors that lead to transfusion-related immunomodulation, and leading the Th1 Th2 ratio, and also decreasing the NK cells, CD8 cells, ultimately have been associated with cancer growth and invasion. And the studies have been very strong, and these have found that colorectal and head and neck surgeries and lung surgeries have been associated with poor cancer outcomes and there is a strong association between transfusion of blood products and cancer recurrence. But we have talked about both the things, but what are the options that we have in these patients? So there's an emphasis on the patient blood management. If we look at this image, there's the first pillar, second pillar, and the third pillar, and we focus on 3 phases: pre-operative, intraoperative, and post-operative. First is to optimize the erythropoiesis. We'll make sure that we cure and treat the anemia and prevent it from developing. The first is whenever you get a PSC and a patient in the PSC clinic, you see if it's an anemia is there or not. Then you identify why there's an anemia. You can go for iron profile and see the B12 and folate deficiency. You can cure that. Identify any underlying disorder, any hematological malignancies, or any other specific reason that is there. Then you manage these disorders. Treat the suboptimal iron stores and iron deficiency. Then treat other hematinic deficiencies. And in intraoperative period, you can time the surgery with hematological optimization. But this is not very feasible in our setup because cancers are time-sensitive surgeries. But we should start these management as early as possible, no matter what of the time is available with the oral or even we have an option of IV iron therapy. Then in the post-op, we should there's an option of stimulating the erythropoiesis. Be aware of the drug interaction that can increase the anemia. So by this, we are actually optimizing erythropoiesis and the hemoglobin of the patient beforehand. Then there's a second pillar, that is, even if whatever the hemoglobin level is, we stop the bleeding and we minimize the blood loss in these patients. So how is it feasible? In the pre-operative, we identify the patient who are at a bleeding risk. If the patient is having clopidogrel or aspirin or any other bleeding disorders, or there's a liver metastasis that can lead to the decreased coagulation factors, we have to identify them, treat it with vitamin K or any other FFP transfusion, so that beforehand we are actually reducing the blood loss risk. Then planning and rehearsing, then pre-operative autologous blood donation is also an option. Then intraoperatively, surgical techniques and anesthesia techniques that can provide good hemostasis and decrease the risk of bleeding, like some cautery, electric cautery, CUSA. And these are the surgical techniques that surgeon can use to minimize the bleeding. Then from anesthesia point of view, the hypotensive anesthesia techniques can be used to minimize the blood loss, like especially in the liver resection surgeries, when the surgeon asks for a low CVP and wants a lower BP. Then other is an autologous blood transfusion. Then pharmacological and hemostatic agents can be used intraoperatively. And in the post-operative patient, we should be very vigilant to identify if there is any secondary hemorrhage, if there is any bleeding. There should be more focus on keeping these patients warm and maintaining normothermia. Then autologous blood salvage can also be done when collected blood in the drains. Then minimizing iatrogenic blood loss, hemostasis, prophylaxis of upper GI hemorrhage if it's there. Then avoiding and treating the infection very vigilantly. And now coming to the third pillar, that is harnessing and optimizing the physiological reserve of anemia. That is, we assess and optimize the patient's physiological reserve and the risk factors. We compare and estimate the blood loss and patient-specific tolerable blood losses preemptively. We formulate patient-specific management plan that are appropriate for blood conservation and modalities to minimize the blood loss, and we have a detailed discussion on them. Then we may optimize the cardiac output, ventilation, oxygenation, so that the main reason why we are treating anemia, that is oxygen delivery and the functional capacity of the patient, should be optimal. Then in the post-operative period, maximizing the oxygen delivery, minimizing the oxygen consumption, decreasing any kind of stress, pain, hypothermia. Again, these are the important pillars of the patient blood management. So, but what is the threshold for actually transfusing in these patients? In our setup also, we have a very restrictive threshold. We don't transfuse or think about transfusion till 7 or 8 hemoglobin. But if there's a acute coronary syndrome or any cardiac disease is there, then only we go for a higher hemoglobin level like 9, and we keep a target of hemoglobin of 9 or more than 9. So this is to be kept in mind, especially when we are dealing with onco patients. Now, another important aspect is the nutritional optimization. It has been found that the incidence of malnutrition is as high as 28 to 57% in these patients. Often these patients come with the first symptom that they had a significant weight loss, 10 kg, 5 kg in the last 1 week. That's why they visited a physician and they were diagnosed. This can be due to tumor-induced metabolic abnormalities, cancer cachexia that is called, and then there's inadequate intake, metabolic inflammatory cause. The patient may have nausea, diarrhea. It can be chemo-induced, or it can be due to the tumors like gastric outlet obstruction or any oral mass or tongue mass, and the patient is, or esophageal mass, the patient intake is reduced because of the tumor. Then anti-cancer therapies can also lead to anorexia and GI derangements. So these patients are often at a risk of malnutrition. But why are we so bothered about this? It has been seen that it can lead to increased risk of post-operative complication with poor wound healing and prolonged length of hospital stay. There's a delay in the recovery of bowel function. There's a decreased immunity, higher rates of readmission, and there's increased incidence of post-operative death also in these patients. So the aim of nutritional optimization is to correct the long-standing nutritional deficits, plus optimizing these patients to pending catabolic insults in the perioperative period. As we know, it's a perioperative and perisurgical recovery period is a catabolic state. So we have to ensure they are optimally neutral, optimal in the nutrition side of the in the nutritional side, so they don't turn up into a catabolic state. We have to increase the energy intake, treat the nausea and vomiting, try to increase the appetite recovery, achieve anabolism, and integrate nutrition with exercise. You can, according to their diet preferences, we advise them the high protein diet, guide them if they like some patients, if they are not able to take large meals, we encourage them to take small, frequent meals. Then if they're like vegetarians or they have a diet deficit in proteins, we encourage them to have protein powders or take dal and eggs. And if they're non-vegetarians, they can also have chicken in their diet. So they have a good energy rich and protein rich diet. These are some of the screening tools for malnutrition, like a malnutrition universal screening tool, NRS, Rayleigh's NRS, NRI, and SGA. And we should be aware of some clinical markers that shows that indicate towards the increased nutritional risk, like if the patient comes with a BMI of less than 18.5, or there's acute weight loss and of 5% in 4 weeks or 7.5% in 12 weeks, or actual weight is less than 90% of the ideal weight. Then there's a sarcopenic obesity, that is, the patient is obese, but there is depleted muscle mass, and there is a transthyretin or low albumin level in these patients. So it is reasonable to delay the surgery after discussion with the surgeon to optimize the nutritional status so the patient recovery can be optimal. So the modes of enteral feeding, the different type of feeding is enteral feeding or parenteral feeding. Enteral feeding is always encouraged as it increases the stimulate the hormonal secretion, promote the portal circulation, maintains the GI barrier, and maintains the immune function. But if the patient, we know that the enteral nutrition is not possible, or there's 7 to 10 days of parenteral nutrition is recommended in the severely malnourished patients. So the total parenteral nutrition is considered to compensate for the nutritional deficiencies of the enteral nutrition. If the patient is not able to take the nutrition, even in the post-operative periods, we know that there's a bowel function may be hampered. There's a lot of anastomosis. Then also some of the surgeons, after discussion with the surgeon, we start the TPN in the perioperative period. It can be TPN. Another option now commonly available is peripheral parenteral nutrition. That is that lacks some of the nutrients, but it can be easily given in the peripheral line. It can be given adjuvant to the enteral nutrition also. Now, some of the positive data has come up regarding the immunonutrition, and it is recommended to supplement at least 7 days pre-operatively to all major elective gastrointestinal surgeries. But the dose is unclear. These include glutamine and omega-3 fatty acids, like fish oil can be recommended in these patients. Now, another very problematic thing with dealing with cancer patients and most ignored is this psychological distress. These patients suddenly come up across a cancer against cancer, and it's a sudden emotional burden and emotional taxing thing. Then the cost of the treatment, these patients often end up with anxiety and depression. So it's not just the anxiety and depression, but it can also have a negative impact on the immune dysregulation, poor wound healing, greater post-operative pain, and prolonged functional recovery with poor quality of life. The psychological preparation for the surgery may improve the outcomes. We can encourage them to have deep breathing exercises, relaxation, yoga, music therapy by a trained psychologist. And in our institute, we have a oncopsychologist that if we see that patient are at a high risk, we often refer them, so they evaluate and help them out in during this phase. It also enhances and reinforces the patient motivation to comply with the exercises and also the nutritional aspects of the intervention. The patient is happy, then they have a better compliance to these techniques. This table shows that there's a for the prehabilitation, there's a time period of 2 to 6 weeks, sometime 8 to 12 weeks. But as we discussed, cancer being a time sensitive, we cannot postpone it for like 1 or 2 months. So whenever we come across the patients in the PSC clinic, whether the patient is going to be posted 1 week or 2 weeks or 4 weeks, maybe, we try to send them to physiotherapists, get a nutritional evaluation, and evaluate them after talking them about the anxiety, depression, if they have any other problem that they have, encouraging them to have breathing exercising, smoking cessation as early as possible without delaying it. The main barrier, as we discussed, is cost, transportation, compliance, but there's always we always encourage them to have home-based prehabilitation, and we can have a telehealth. Like some of the patients who are high risk, we share our phone number so that we can look after them, and we can, if they have any issues, they can contact us on WhatsApp so that we can encourage them in the future direction, and we can have a good contact with them. Now, I think everything that we have discussed till now, all focus then comes down to IRAS, that is the enhanced recovery after the surgery. It actually includes a series of preoperative, intraoperative, and postoperative interventions to improve and enhance the recovery from surgery and anesthesia after major surgical procedures. IRAS has been given for almost each and every surgical different type of surgery that is there. And if you look into the components, we see that the prehabilitation is an important aspect of IRAS also. The prehabilitation complements actually IRAS in promoting early return to baseline functional capacity to potentially increase the chance of timely return to post-operative adjuvant cancer therapies. So the main aim is not to just resect and make the patient tumor-free and cancer-free. We need to make sure that the patient is returns, the functional capacity returns as soon as possible so they can jump to their normal life or may jump to and be more compliant towards their next treatment that can be chemotherapy or radiotherapy. So if we look briefly into the different components of IRAS, preoperatively, the counseling, that is seeing the patient, talking to them, giving walking down to the procedures, then fluid and carbohydrate loading, prolonged fasting has been discouraged. Very selective bowel preparation is done right nowadays. Then antibiotic prophylaxis, thromboprophylaxis are the important component. Intraoperatively, we go with the balanced anesthetic techniques. So ensure that the adequate depth and good analgesia is there, and we ensure that the patient recovers quickly. Goal-directed fluid therapy, avoiding fluid overloads, doing very restrictive type of blood transfusion protocols, then maintenance of normothermia. And in post-operative, we encourage regional anesthesia, good pain control, avoiding nasogastric tubes because this can be very can decrease that can cause a lot of irritation to the patient. Avoiding giving good prophylaxis for nausea, vomiting, then removing of the invasive lines and catheters as early as possible. Early return to oral nutrition, non-opioid type of oral analgesia is encouraged because opioids are often associated with immunomodulation and also side effects like nausea, vomiting, constipation, and ileus also. Then early mobilization, starting physiotherapy is as early as possible. So this is everything that we have discussed actually comes down to, right, that is return to intended oncology treatment. There's a lot of data that is related to safety, that is harm or avoidance of negative outcome, like 90-day mortality rates. But no one is talking about the midterm cancer-specific outcomes, like pain relief, freedom for further cancer therapy, or functional recovery are actually lacking. So after the cancer surgery, complications and disability often prevent some patients from receiving subsequent treatments. Like if the patient was very low body weight, was very low compliant, and we take them instead of rehabilitation, we take them to surgery. When the post-operative, they land up with post-operative pulmonary complication, and there's wound days and there's infection. These patients, the chances of them going into the next treatment, the treatment like chemotherapy they were supposed to have or radiotherapy, that gets further delayed. And we want the patient to return to their initial functional capacity as soon as possible. So, given that the inability to complete the intended cancer therapies might actually negate the oncological benefit of surgical therapy, that you have made the patient maybe tumor free, remove the tumor, but is the patient good enough to return to its functional capacity, initial functional capacity, and to perform his daily activities or not? So, continuous evolution of anesthetic techniques and surgical approaches and tools to measure recovery have improved the patient safety and quality significantly. Some of the important components are goal-directed fluid therapy, narcotic minimization, alternative analgesic strategies, PONV, hypothermia, then minimizing oxygen depth. All these other components. And if you look into the whole of the slides that I've discussed, like these same things that come again and again from rehabilitation to ERAS to RIOT also. So main aim is like that whenever when the cancer is first diagnosed, till the surgery and the post-op. So our role is not just confined to ensuring that the patient is patient-free and patient is not moving in the OT and all, but we have to ensure that the patient is very much fit when we are taking the patient in the surgery, is good rehabilitated. We follow all the protocols, ensure the early recovery, and the patient is good to go, return to its original life or to the next whatever the next treatment modality is there. So this is what I will like to everyone to note that this is what is actually oncology, like onco anesthesia is there. Like we need to focus on all the aspects of when we are dealing with these patients.
Thank you so much, Pratishtha, covering from anesthesia, cancer recurrence to prehabilitation to ERAS and RIOT. You have covered intra-op and peri-op. So thank you so much for such a wonderful presentation. And now one of my favorite topics, that is airway management in oncosurgeries. And there cannot be a better person than Dr. Apeksh. Dr. Apeksh, over to you.
Good evening. It's a pleasure to be here on this platform. And thank you, Dr. Meenakshi Sundaram and Team Anaesthesia-Puthukkottai for giving me an opportunity to speak on the airway management for oncosurgery. So it's a balancing act between the oncosurgical requirement, patient anatomical factor and alteration, and an anesthetist's ability, skill, and experience to manage such complex airway cases. And with varieties of oncosurgery cases, we'll get the different varieties of the patient, like CA tongue, buccal mucosa carcinoma with a narrow mouth opening, CA thyroid, CA upper lip, CA lip cases, redo surgeries, post-hemimandibulectomy cases for the redo surgeries, nasopharyngeal mass extending into the oral cavities. And over and above that, in post-surgical or oncosurgical cases, extubations become more challenging. So you have to handle such type of cases. And if you look at a different oncosurgery, the airway management method, technique, process differs with different oncosurgery cases. If you look at the intraoral surgery, oral cancer, laryngeal tumor, hypopharyngeal surgeries, diagnostic scopy, the airway management is totally different when we do a laser surgeries, interventional airway procedure, when we share the airway with the surgeon, then the management is totally different. Even that differs with the head and neck cases, tongue cases, buccal mucosa and microvascular flap also. And in certain group of cases like mediastinal mass and thoracic, we have to handle the lung isolations. While in certain tracheal surgeries, you need to apply apneic oxygenation and you need to apply jet ventilation to maintain the oxygenation. And if you look at the thyroid surgery, from pre-op to post-op, airway management is totally different from what you do in a tracheal surgery and thoracic surgery. So, airway management in oncosurgery is case specific. So, and there are two different varieties of airway when you handle the oncosurgical cases. One is difficult airway. When an expert airway operator finding difficulty with laryngoscopy, mass ventilation, supraglottic insertion or surgical access. So it's about the access to the airway. While compromised airway, where there is an anatomical or physiological obstruction to the airway during the airway management. Like example in a tracheal compression with the thyroid swelling, tracheal stenosis, CA trachea, mediastinal mass. So when you handle the oncosurgical cases, many times you get combination of compromised airway and difficult airway. We can label this airway as a complex airway. So in oncosurgical cases, you have to handle the complex airway rather than difficult airway and compromised airway. It's a combination of both. So success of airway management in oncosurgical cases is a highly complex phenomenon when you need to take care of patient factor, operating factors, available resources, decision making, and time pressure. If these five things fall in together, then you'll be having a success in such type of complex airway cases. So how to evaluate, what are the patient factors and how to evaluate the airway in oncosurgical cases? So you have to identify the difficult airway by the clinical conventional predictors. But over and above that, you need to assess the airway as per the cases. It's a case-specific airway assessment. Let's look at the few tongue cases. Suppose this is a CA tongue, lateral side of the tongue. Here you need to check whether tongue is fixed or mobile. Is possible to protrude the tongue or not? Or this lesion bleeds with the touch or not? Or many times you need to check the compliance of the tongue. If it is a steep, stony hard, then it's very difficult to retract that tongue with the direct laryngoscopy. And when you get the base of tongue tumor, so this tongue become hypopharyngeal, and you with the direct laryngoscopy, we are usually retracting the oropharyngeal tongue. It's very difficult to retract the hypopharyngeal tongue. So this type of airway assessment you have to do with the different cases. Suppose if you look at this case with the CA lip, which is extended up to the mandible, or post-hemimandibulectomy case. In such cases, extent of the growth we have to check it with the endoscopic evaluation or by the scan. And on clinical basis, you find difficulty in placement of the mask and ventilating with the mask. So this is how you have to make a plan according to the cases. This is another case where you find this is nasopharyngeal mask extending up to the oropharynx. But further evaluation is required with the scan, with the virtual endoscopy, with the actual endoscope. Same as with these cases where there is a recurrence of buccal mucosa with the flare. So intraoral lesion, for checking the intraoral lesion, you need to have a radiological investigations or endoscopic evaluation. And these post-radiation head and neck cases are most challenging because in such cases, there is a significant decrease in the submandibular tissue compliance. So when there is a decrease in the submandibular tissue compliance, it's very difficult to retract, compress the tongue between the laryngoscopic blade and the mandible. And even if you want to take this patient in an awake state, it's very difficult to identify landmark for giving the airway block. In such case, you have to make a use of airway sonography to identify the structure and give the block. Or else you have to go as spray as you go technique. And in specifically lung cases, there is a compromised gaseous exchange or reduces of functionality of lung. This causes physiological difficult airway. And as you know, thyroid are another challenging, huge thyroid is another challenges with the airway management during thyroid surgery. You have to evaluate this thyroid with the clinical markers like dysphagia, postural dyspnea, stridor, and you have to predict the difficult airway by the measuring the circumference of the neck. And even you have to go with the radiological investigation like X-ray, chest X-ray, USGs, and scan to identify the tracheal compression and deviation of trachea, and you have to identify the compromised airway. So in which cases you have to proceed or assess the airway with the flexible endoscope. Like certain cases like base of tongue, you have to do a endoscopic evaluation to see the extent of the growth when it is a base of tongue, because there are likely chances of collapse during the airway management. Nasopharyngeal mass, laryngeal tumor, tracheal tumor, intraoral lesions. Specifically in thyroid carcinoma, you have to check for the tracheal compression, whether it's external or internal, or you have to identify the vocal cord palsy in case of thyroid carcinoma. This is one of the endoscopic evaluation where we found the right side vocal cord palsy of right side thyroid cases. Even many times, even with the endoscopic evaluation, this case of CA focal cord, so we are not able to negotiate the scope beyond the lesion. So that's the limitation of flexible endoscope. So what we have to do? So these are, we'll discuss that later. So this is another case where nasopharyngeal mass extending up to the oropharynx. Look at this scan. Look at the imaging. So look this area. There is extensive growth in the nasopharynx which extend up to the oropharynx, up to the epiglottis. So what is the limitation of endoscopy as far as evaluation of the airway is concerned, or even limitation of scan as far as evaluation of airway is concerned? So with the endoscopic evaluations, many times you can't negotiate the scope beyond the lesion because of significant narrowing. And most of the anesthesiologists are not used to read the scan. So that are the limitation. For that, you have to go ahead with the virtual imaging. So virtual imaging gives you a data as per your conventional anatomical perception. So what is virtual imaging? It's nothing but 3D reconstruction of images from the original Excel CT data set. This is one fly-through image of the virtual endoscopy. You can, in most of the virtual endoscopy, you can identify the passage of the airway if you are selecting for the awake video laryngoscopy or awake flexible endoscopy intubation. Even you can have a view of the external or adjacent structure to the airway. What structure is compressing the airway, that you will be able to identify the exoscopic view of 3D imaging. So with the virtual imaging, you can identify the complexity of the airway, whether it's a compromised airway or whether it's a difficult airway. And you can have both static imaging or dynamic imaging. In short, virtual imaging, you will be able to identify the stenosis segment, will be able to view beyond the stenotic segment. You can have an external surface, view of external surface in relation to the adjacent structure. And you can have a view of retrograde view, looking from where that is not possible with the conventional endoscopy. Look, this is antegrade conventional endoscopy. You can't have a view from the behind. So with this is the retrograde view. Virtual endoscopy, you can have a retrograde view also. But with the exoscopy view, you can identify which structure is compressing the trachea, or you can identify the tracheal stenosis from the external view also. So this is another 3D virtual imaging where thyroid compressing the trachea, you can easily identify the area of compression, extent of compression, and severity of compression with virtual imaging. And even with the dynamic scanning during inspiration expiration, you can measure the diameter of the trachea and identify whether it's collapsing or not, and you can diagnose the tracheomalacia. Specifically in bronchial 3D imaging, you see, look at here, lymph node is compressed, external mass, lymph node is compressing the left bronchus. So by even measuring this compression, you can select the size of endotracheal tube if you need to go with the one lung isolation technique. So virtual endoscopy or virtual imaging is a useful complementary method of 3D imaging when there is a compromised airway lumen. And it may be prove superior to fiber optic endoscopy in severe stenosis or obstruction where the endoscope cannot be passed through. So nowadays, airway ultrasound is a part of any oncosurgical procedure. You can measure the tracheal diameter for identifying the size of tube, size of double lumen tube. You can see the extent of thyroid growth. You can extent of thyroid growth beyond the clavicle. You can identify the restosternal extension also with the airway USG. Even you can assess the vocal cord movement with the airway USG. You can even with the USG, you can identify the cricothyroid membrane sting of pulse appearances. These are the tracheal rings. This is cricoid cartilage. This is thyroid cartilage, and this is cricothyroid. So it's mandatory to locate the cricothyroid membrane in all oncosurgical cases, either by clinical method or by the sonographic method. So this is another so many times with the post-radiation cases, head and neck cases, you are not able to identify the hyoid. So very difficult to identify the hyoid and to give superior laryngeal nerve bone. So in such case, you can use the ultrasonography. This is the hyoid bone. This is a thyroid cartilage. This is thyroid membrane, and you can see here there is a pulsation which is showing the superior laryngeal artery adjacent to the superior laryngeal nerve. So for SLR block, you can use the ultrasonography. So now, apart from the patient factor, when you are managing a complex airway oncosurgical cases, where whatever the location is, there should be availability of difficult airway card, which includes video laryngoscope, direct laryngoscope, flexible bronchoscope, airway adjuvants to the cricothyrotomy set, to jet ventilation and ventrate. And there should be availability of expert hand when you are going to manage such complex cases. And there is specific need in the specific cases. In most of the DL-scopy, we are using the high flow nasal cannula. In certain tracheal surgeries, you can use the vent and you can use the jet ventilation. And usually in head and neck cases, you need to have a north pole tube. And for flexible endoscopy, we are using the Farkat flex tip with the wire reinforced tube, which minimize the laryngeal impingement. And you should have airway block ready for all the cases. So decision making is most critical part of when you are managing the complex oncosurgical cases. So you have to select the right patient for a right technique with the right device with optimal skill and experience and the peace of mind at the right place. Then we will be having a success in the airway management. So how to make a decision? It's very easy. First you have to make a differentiation whether you want to go with the awake or you want to go with the anesthesia. If there is a difficult mass ventilation, difficult intubation and compromised airway, then we should have to go with the awake airway assessing technique. Otherwise, you can go for the anesthesia. So once you go with the anesthesia, then you have to decide, should I go with the relaxant or should I go with the spontaneous breathing for induction? So cases like huge thyroid mass with the tracheal compression, tracheoesophageal fistula, certain interventional area procedure, you need to induce a patient in a spontaneous breathing. While in the rest of the group, you can go ahead with the relaxant. Now, when you are selecting the relaxant, whether you have to select versus succinylcholine hydroquinone versus the other relaxants, you have to select the relaxant during induction, which is having faster onset of action, because with the faster onset, you will get the faster intubating condition, and even the mass ventilation efficiency improves after the relaxation. To ease out this problem, ease out decision making, AS has given the guidelines. So if you suspect a difficult laryngoscopy, difficult intubation, if you are suspecting difficult ventilation, or there is increased risk of aspiration or increased risk of rapid desaturation, go with the awake airway management. So when you are going with the awake airway management, you are having again two choices: awake intubation or awake surgical access. So in which case you have to go with the tracheostomy. The case is, suppose tongue cases, when tongue lesion crosses the midline, there is a tongue, then this is the cases is a selection for the prior tracheostomy before a surgery. Or mandibulectomy is a case for the prior tracheostomy. Or major flap surgery is a case for the prior tracheostomy before awake state. Now, then when you are going with the awake intubation, you have to follow one of the guidelines. So this is the DAS ATI guideline, awake technical intubation. So first you have to sedate, then you have to anesthetize, topicalize, oxygenate, and then perform. But here S is small and red. So sedation should be avoided in a complex airway cases where you find a compromised airway as well as difficult airway. So you are having a number of choices for awake intubation. Usually in our clinical settings, we are either using flexible endoscope, video laryngoscope, and awake hybrid technique. Retrograde technique and blind nasal, we are usually reserve it for the teaching purpose. Routinely, we are using this flexible endoscope, video laryngoscope, and awake hybrid for awake intubation. So this is one of the intubation with the flexible endoscope. So to having a higher success rate, there should be a proper patient cooperation, optimal, your skills should be optimal, and staff coordination. And you have to prepare everything before proceeding for the flexible endoscopic intubation. Then and then you will be able to perform the flexible endoscopic intubation in a 45 to 55 seconds. Now, question is that when to go for awake PL and when to go for awake flexible endoscope. So when there is a narrow mouth opening, and if your video laryngoscope that cannot be inserted into the oral cavity, then only choice left which is awake flexible endoscope. So when there is a difficult mass ventilation, but mouth opening is good, in such case you can select awake VL video laryngoscopy for it. This is one of the cases where we have in the bilateral superior laryngeal nerve block. We could identify the hyoid and give the block. Transprecoid spray. With the nasal lubrication, we have passed the nasal tracheal tube up to the pharynx. And when we are asking the patient was able to open the mouth and could easily do the awake VL and negotiate the tube inside the larynx. The tube is passing into the larynx easily. And patient is fully awake. Look, patient is open, closing the mouth, is lifting the head. So even these cases, when there is a good mouth opening, but compromised airway, in such case, you can use awake video laryngoscopy. Even with the thyroid cases, use thyroid, mouth opening is good, you can use the awake video laryngoscopy. So now question is that, so there are a number of video laryngoscope are available in the market. So which video laryngoscope to be used? So it's an angulated, anatomically curved, J-shaped, hyperangulated or Macintosh type. So when you are predicting difficult airway, always go with the hyperangulated way because it's having higher success rate. And specifically in awake video laryngoscopy, you should go with the anatomically curved blade, hyperangulated or channel J-shape. Now, and no Macintosh type of VL for awake. Why? That we'll discuss later. So, if you compare the hyperangulated blade with the channel J-shaped blade, so time to intubation is significantly less with the channel blade compared to the hyperangulated blade. So it's a less time, so it's beneficial for the awake tickle intubation. Now, why anatomically curved blade for awake tickle intubation? Why not Macintosh? So when anatomically curved blade in C2, the tongue is going to lie on the anatomically curved blade. So force of laryngoscopy is significantly less with J-shape or hyperangulated blade. So patient tolerability of this blade is better compared to the Macintosh type of VL where you need to generate the force. In certain group of patients, you need to apply a hybrid technique. Here, with the channel video laryngoscope, the tube is in the channel and scope is passing through the tube which is inside the channel and negotiating the scope through the tube, negotiating the scope into the larynx and over that, rerouting the endotechal tube inside the larynx. So this is another case where we are finding difficulty in negotiating the tube with the nasotechal intubation into the larynx with the video laryngoscope. So in such case, we have kept the video laryngoscope in situ and through the tube, we have passed the scope. Scope is coming out of the tube. This is a video laryngoscopic tube and scope is going into the larynx. And then over the larynx, we have passed the endotechal tube. So when awake hybrid technique to be used, when you are using the nasotechal intubation or oral intubation with the channel blade, if your tube is impinging over the laryngeal inlet, or if your tube is sliding into the esophagus after all maneuvering, then this is the technique. Awake hybrid is the technique to be applied for. Certain vocal cord lesion, use thyroid with the tracheal compression, glottic lesion, you should go with the awake hybrid technique. So success of awake tracheal intubation is highly dependent on your airway anesthesia. You can have a combination of technique for airway anesthesia from airway block to airway surface anesthesia, automizers, nebulizers, gargles, sedation, spray you go. Usual in a technique is different for the awake VL and technique is different from the awake fiber optic. What are the concerns of airway block? In a oncosurgical cases, one, altered anatomy, not able to identify the landmark, specifically in post-radiation stiffness, bleeding. So in such case, make use of ultrasonography. So for VL, what we are using, what type of anesthesia we are using. So this is Medgesic device. So you can generate the particles of the local anesthetic agents. And you can insert some malleable device. You can insert it and spray over the larynx. Look at this. This is one of the case for awake VL where you anesthetize the posterior pharyngeal wall with the spray. Once you spray over the posterior pharyngeal wall, wait. Then patient will allow to do a video laryngoscopy. And with the MAD, Medjessic, you can spray over the larynx and beyond the larynx also. This is how you can achieve the optimal anesthesia for awake wear. So for awake flexible endoscopic intubation, for trigeminal area, nasopharynx, we are using the lubrication with the xylocaine gel or atomizer. For glossopharyngeal area, we are using 10% spray or Medjessic spray with the local anesthetic. And specific area from area below to inferior to epiglottis to vocal cord. For that, we are using the superior laryngeal now, and infraglottic area, we are using transcricoid spray. This is one of the video of superior laryngeal now. So you have to insert the needle perpendicular skin plate just underneath the greater corner of the hyoid, up to 1.5 to 2 centimeter, and inject the local anesthetic by withdrawing the needle. And you have to repeat the same injection, same technique on the opposite side. And this is another video showing the transcricoid. So first, locate the cricothyroid space and insert the cannula inside the cricothyroid space. Aspirate the air. Remove the needle. Keep the cannula inside. Each of the two persons is one of the landmarks in the flexible endoscopic intubation. And if airway anesthesia is inappropriate, you can reinstill the local anesthetic. And once you are inserting the needle is inside, you can aspirate the air and instill the local anesthetic in the infraglottic region. Important tips: avoid sedation during awake intubation when we are managing the complex airway. Because look at this video. With awake intubation, epiglottis is totally lifted up. There is no collapse. But with asleep FY or asleep patient, the epiglottis is touching the posterior pharyngeal wall. There is a significant decrease in anteposterior depth of the pharynx. So this creates a difficulty in negotiating the scope underneath the epiglottis. So avoid sedation during awake tracheal intubation. Suppose you are going for a general anesthesia in cases where you are finding difficult mass ventilation. So what is the alternative to pre-oxygenate the patient and ventilate the patient? This is the alternative. Insert the appropriate sized nasopharyngeal airway. Connect the nasopharyngeal airway with the circuit. You can pre-oxygenate also, and with this technique, with the nasopharyngeal airway in situ, you can ventilate the patient also. You can see the ventilating the patient by obliterating the opposite nostril and closing the mouth. And nasopharyngeal airway in situ, which is connected with the circuit to the ventilator. And you can very well appreciate the CO2 waveform. To extubate this patient. So most of this complex airway is at this extubation. So how to manage? So all the extubation. So you need to decide whether you want to go with the tracheostomy at the time of recovery or you want to extubate this patient. So if you want to extubate this patient, all patients should be extubated with the conduit inside. That is airway exchange catheter. It's a 83 centimeter long hollow tube. So this is one of the video showing the method of extubating a complex airway with the help of AC. Passing the AC up to the optimal depth inside the tube into the trachea. and over the AC, removing the tube. So in case reintubation is required, conduit is ready for you to reintubate the patient. That increase your and patient safety significantly. And certain group of patients with the thyroid cases, you have to extubate over the flexible endoscopy. So you can diagnose the tracheomalacia if it is there. If it is there, you can reintubate through the flexible endoscope. This is the tracheomalacia, significant decrease in the epidiabetes. So IDA has given the guideline for at-risk extubation. So it's a safe protocol. First, stratify risk, anticipate, facilitate, and then escalate. So according to All India Difficult Airway Association guideline, most of the oncosurgical cases fall into limb 3, where you are suspecting the postoperative airway collapse, airway edema, and there is a surgical cause of airway compromise like flap or interdental wiring. So if you end up with the 3S, you need to decide whether you want to go with the tracheostomy or you want to extubate the patients. And when you are extubating a patient, then you have to do planning for extubation, then you have to do a cuff link test. If cuff link is absent or equivalent, do not extubate, wait, consider giving steroid. But whatever the extubation plan you have, always keep the difficult airway cart ready with you. Ensure adequate recovery from the residual neuromuscular blockage using the neuromuscular monitoring, and always retreat the lung. And throughout the process of extubation, continue oxygenation. So you have to many times delay the extubation. And when you are planning for extubation should be done over the AC or the flexible endoscope or with the wire. And after extubation, if obstruction persists, you have to reintubate and then plan for a tissue. And after extubating a patient, always consider giving the CPAP and IV of HFNO. So because of lack of time, I'm not going to discuss the shared airway, specifically laser surgery, tracheal resection, anastomosis, interventional airway procedures. We have to share the airway with the surgeon, and where we need to make the use of rigid bronchoscope, train, menujet, HFNO, and it's a tubeless surgery. That is a totally separate talk. And when you need to look at the triage of fire, and you have to prevent the fire by limiting these 3 things. So in short, in a complex oncosurgical cases, airway management is a complex phenomenon where you have to consider the patient factor. You need to consider your skill and experience. You should have optimal available resources, and you should be clear about your decision-making ability. And you have to perform in a proper time frame. Then and then you will be having a success in such complex airway cases. So we are running a 3 days on-patient training course for the flexible endoscopic intubation. And we are also running the fellowship in advanced and difficult airway management. It's a 4-month staff-undery seat. And you can find out the number of airway videos on our Anesthesia YouTube channel, Anesthesia XROAD AA. Thank you.
Thank you so much, Dr. Apeksh. It was wonderful practical tips for onco airway management. So after these extensive 3 talks, with your consent, should we take the question, sir? Meenakshi, sir?
Yes, madam.
Okay, so let me look at the chat box and see. The first question is, all surgeries elicit metabolic response, whether oncosurgeries metabolic response is different from no malignant surgery. Pratishtha, to you.
Ma'am, actually, the thing is when we are talking about the inflammatory response and of the body in the non-oncological surgeries, basically for healing and helping the body recover with the damage. But as I talk about the immunomodulation, thus in the patients of the cancer patients, we are not only talking about the healing, but it also has an impact on immunosuppression. That is, how the metastatic and micrometastatic cancer cells that have disseminated and that we are actually not able to see by the bare eyes, if that also influences their survival and whether they will in the long run will go and metastasize to the new places. Apart from them, the metabolically the cancer cells are quite different. They are because of the way it itself has a inflammatory response that leads to the catabolic state of the patient, and these patients have a high energy requirement. So there are multiple factors that makes these patients quite different from the normal patient, non-oncological patients. So when we are talking about pain management or activation of sympathetic system or hypothermia, blood transfusion, these patients not only for the perioperative period, but for the long-term cancer recurrence and the reappearance of the cancer, it becomes more important from these point of view in oncologic setups and as compared to the others.
That was good that it is totally different. So if we want to elaborate it, it has a lot of other factors. So the biggest factor is the tumor itself. So coming to the next question is, okay, I'll put it like that. Do you use TIVA technique just because it will, not do anesthesia cancer recurrence as compared to the other technique? And is it cost effective?
Ma'am, we are actually not regularly using TIVA techniques as compared because as I also said, the most of the studies are in vitro that have come up, and then the results were mostly initially that came up was the breast surgeries, and later on there were some contradictory results also. And so there's no clear-cut evidence that can completely state, as I saw told that we should stop completely using volatiles and we go to TIVA. And plus, as we talk about the cost effectiveness, the propofol and using TIVA completely, it's uh, it's very expensive for the patients, the amount of propofol that we are using. And moreover, apart from that, it's not only one thing that is going to affect the cancer recurrence, not only just propofol or volatile agents, but there are like pain, there's blood transfusion. However, there are various other factors that are compositely acting, and we are still studying and we are still waiting for good RCTs so that we can have a very clear cut and good evidence while we should completely discard using volatile agents.
So Dr. Apeksh,
Madam,
do you have any
one
cases
second.
where you used
Madam,
TIVA? Huh.
Madam, 1 second, madam. See, that question was asked specifically by me because this is for youngsters to take the message. If we say a lot of complicated things, the youngsters may afraid they cannot take up cases in their setup. Because you specifically mentioned that this intravenous anesthesia scores over volatile anesthesia technique means they will be confused. That is the reason why we want you to deliver, because you are experts in the field. Deliver a clear message to the youngsters so that they will be happy to practice in their place. Everything should be feasible. When you say everything should be feasible, the experts should not complicate the issue. They should make it very easy for the people to understand. See, I'll be worried then if you say so much. I'm not having a TIVA pump. Where to go for that programmed pump? How I can use that? Routinely, we use propofol and maintain with the sevoflurane only. Even I say, after the advent of fentanyl, propofol, vecuronium, sevoflurane, anesthesia is very easy for me because I have seen the tougher part also. These 4 drugs makes wonders for all the patients. We can use these 4. Now you recollect it is propofol, vecuronium, sevoflurane, fentanyl. You can manage any case. That is how we have to say. But we will be worried whenever we are dealing with the complicated cases. If you
That's
make
why,
that
sir,
statement,
I mentioned in the table also that these are mostly the results that are coming up are actually the in vitro studies. And when we come across
that
the
is
data
another
and
idea,
the
madam.
evidence that is
Madam,
coming.
1 second, Dr. Pratishtha. That's the reason why I requested you not to talk about research-based slides. Can you recollect? I have said, because I want you people to deliver the clear message. This is the message. So that they will be interested in practicing, they will be interested in delivering lecture also. You are right. But we have to talk to the people who are with MD anesthesia degree,
So, sir,
not to
that I will say that is that give good analgesia. Okay.
good.
You give whatever drugs you are giving. Huh? But you cannot have a drug which you don't give, and at the same time patient is having pain, that equally will increase the other responses. So whatever Pratishtha has spoken is like how you said she won't have to speak about the studies, but anesthesia and cancer recurrence is only by studies which are, most of them are retrospective. Only one is done prospective in the breast case. So right now there is no conclusion. So we will forget about, for the MD students, they will not talk about what is regarding TIVA and inhalation. If they are going for a case outside for an onco case, they should be more aware of what chemotherapy was given to the patient, what are the side effects for it. They have to look for that and forget about TIVA and other co-founding factors, because there's so many co-founding factors. You cannot say alone blood transfusion will do, local anesthetics will do, TIVA will do, or propofol, like whatever drug you are using. So that should be the message for the MD students right now. But yes, if you just put a anesthesia and cancer recurrence, if you see the number of articles and the number of studies done, Dr. Meenakshi, that it has to be a separate topic. Would you add to it, Dr. Apeksh?
Yeah. Thank you for giving me an opportunity to answer this question. So you have to think globally, but act locally as per the resource available and as per your knowledge. That's very important for the PGs.
Okay, coming to the next question, I think she had answered earlier also what hemoglobin level you would like to transfuse the patients, and pre-op and peri-op. Would you like to highlight it again and give a message, Pratishtha?
If we, as we discuss about the blood transfusion, we have very restrictive protocols. Like we don't transfuse in non-cardiological. If as a patient has a history of AMI or any if the patient has CAD or something, then only we have a threshold of around 9. But in our setup, we don't transfuse. In other cases, we don't transfuse at less than 8. Beyond 8, we just have a target of 8 and those patients, and not below that, not above that. We have very
And
restrictive
You are not
policies on
checking
that.
in the 1 minute, madam. You are not checking the hematocrit. Only hemoglobin you.
Hematocrit,
It's
we specifically look into when we are going with the free flaps and free flap patients. We are also checking the hematocrit, but doing regularly the ABGs to check the hematocrit in the intraoperative period, especially when these are 7 to 8 hours, it's not feasible for us also and cost effectively. But in sir, as you rightly said, the hematocrit, we look into that, especially in the free flap, because this straightforward protocols have been said that at least 7 to 8 hemoglobin and 30 to 35% of hematocrit should be there. It helps in maintaining the perfusion of the free flaps in these patients. And these are very long surgeries, so we have to balance it out. The oxygen delivery to the free flap and all that has to be kept in mind.
but sir, as Dr. Apeksh is insisting, it has to be individualized. You cannot say that I will have numbers. We will not treat the numbers. We will treat the patient. We will look at the patient, what comorbidities patient has, what type of surgery, what ages of the patient. If you're getting an 80-85-year-old for a liver surgery, what you would like to have a 9 hemoglobin or a 8 hemoglobin. So it is actually totally patient based, not numbers, if clinically you go. But what she said, by guidelines, and if we have a number, it's always that with comorbidities 7 or 8, and like that we go. So the next question, I think this also she had answered, but when malignancy demands early surgery, how nutrition could be corrected? IV hyperalimentation, Pratishtha?
As we discussed, actually cancer is a time-sensitive surgery. So I also mentioned that although treating the cachexia and the weight loss is a very difficult task and it can take a lot of time. So, at the point where we see the first patient, that is during the PSC clinic, at that time also we start inculcating the good feeding habits like high protein diet, giving dal, enriching their according to the resources. If they're adding eggs to their diets, or adding a high protein diet, if they're not able to take them, especially when they have head and neck cancers and when they are taking liquid diets, we encourage them to have protein powders. And also we simultaneously refer them to the nutritionalist, because we have a dedicated nutritionalist in our setup. So even if when we were not having special dietitians for this, we ourselves encourage these patients. Apart from that, encourage them to have a regular exercises. Along with the feeding, they should have a regular exercise that helps in uh, uh, increasing their lean body mass also. So we encourage it as early as possible. And if it is very usually we don't start TPN or anything in the pre-operative, but in the post-operative patients, we see that especially after discussion with the surgeons, and even the main call is by the surgeons actually. If there's a lot of anastomosis, and we know that it will starting the enteral feeding and oral feeding will be take more than 7 to 10 days, and those patients they start with the TPN and then gradually add the oral feeds, and then they are gradually tapering off the TPN and completely taken into the enteral feeds.
So, Dr. Apeksh, you can add anywhere you want to.
Yeah,
And
fine.
so in this, it is when the patient comes in anesthesia checkup, and by the time he comes on table, there is some time for the patient where we can, optimize until unless it's real emergency. So even though it is time sensitive surgery, we still have time to, in big institutes where there is a time for them to come on the table, say about a week or 2 weeks, at least those time enteral nutrition is much better. And most of the big institutes now have nutritionists from PA checkup, or the moment they come to the surgeon, they go to a nutritionist and a physiotherapist. So that is how the prehabilitation, it really is required for a good outcome of the patient. Anything else you want to add? Okay, sir. Next question is, what analgesic, narcotic or non-narcotic you use in the perioperative period? Shweta, would you like to answer this? Or Pratishtha? Whomever you want to. You can tell what you do in AIMS, she can tell what they do in Tata.
Ma'am, here mostly we use epidural catheter-based analgesia, either with local anesthetics or with opioids. We usually use morphine, sometimes we use fentanyl, and paracetamol and NSAIDs also we use. Sometimes we add, if the patient is already on gabapentin, we continue, or we add it sometimes in the postoperative period. Then sometimes we use catheter facial plane blocks also with catheter in situ in some surgeries, where if it's a major surgery and we're not able to place an epidural because of vascular anastomosis, or if there is any need for heparin that we give intra or post-op, so in those cases we use epidural catheters, facial plane block catheters, mostly this
Pratishtha, anything different you?
Ma'am, main emphasis is on the multimodal type. Like we use paracetamol, NSAIDs, and we also use epidural catheters. And in some cases, we also use intraspinal morphine also. In the epidural catheters, the main preference is using local anesthetics with or without fentanyl. And if there is a lot of hypotension, or if they have on a high NORAD support, then only we continue on morphine, like based on the body weight, 2 mg or 3 milligrams morphine BD doses as required. Most of it's the focus is to balance it out. If the patient is complaining like from the flap side, if it's more of a neuropathic pain, we add carbapenem, as well said by Shweta, in the perioperative period. So if we try to focus to use, we don't try to concentrate mostly on opioids, because itself has a lot of side effects. So we balance it out so that we reduce the opioid as much as possible, and not focus completely on concentrate on opioids.
Dr. Meenakshi, you wanted something else, or is this?
No, ma'am. No, ma'am. You can go to the next question.
Dr. Apeksh, this is for you. Please give an outline of Patwa Shah video laryngoscope.
Yeah. So we developed this device in 2017 and handed over to one of the multinational company. But after that, multinational company has stopped marketing that device. So at present, that device is not in the market.
What exactly you devised, Patwa? This is for the delegates.
It was a video laryngoscope. It's having a non-channel bed, and 360-degree rotation of the screen over the scope. So you can intubate from any side of the patient.
And I had the privilege to see it. It was a good one. So, another question for you, Dr. Apeksh. Have you ever experienced tracheal collapse after cancer thyroid surgeries? If yes, how you managed it?
Yeah, see, the video I have shown in the lecture, that was our video. There was significant decrease in the anti-opposite depth post-thyroid surgery. Usually, we reintubated the patient, and the next day we have converted that into the tracheostomy. But on a longer period of time, if you want to manage the tracheomalacia, there are two ways. One, you can do a tracheoplasty. So you have to identify the rings which is collapsible, which is softened. So take a stitch over that ring and fix it with the clavicle. Now that's called the tracheoplasty. And the second method, if the tracheomalacia is persisting for a longer period of time, then another option is a stenting. Take a stenting.
So in the early years, it used to be only the dictum used to be tracheostomy. Now people are doing stenting. They're using continuous positive airway pressures, keeping the patient like that. But as such, per se, tracheomalacia is not diagnosed properly. So if you see the number of like how, sir, yours, Dr. Peksh, what you showed was a very characteristic one. So I don't know how many tracheomalicias you have seen in your.
Yeah, I have seen only once. Only once.
That's what I
And
said.
Have you managed, Dr. Patwa?
so
That
on the next day, we have converted into the tracheostome.
lifelong tracheostomy or what?
No, after 6 months, patient didn't come for the follow-up. So after 6 months, I don't know what happens to the patient.
Because you are fortunate you have seen. I have not been fortunate to see a case of tracheomalacia.
I have seen in my 30 years, at least 4 or 5 I have seen easily, like which can be, and the amount of depends on the huge thyroids, which you say just by palpating only, we would ask him, do you think they will have? So not all of them will have, but yes.
And I think,
Sir,
yes.
Pratishtha, you want to say something?
Sir, I wanted to know, you mentioned stenting. So, is it feasible? Like, we understand, like, if the patient is not operated or later on it develops, we can put a stent over there. But is it feasible, like, pre-operatively or peri-operatively? Will it not be displaced or anything? No.
Not
So
pre-operative.
mostly when the later on it develops, we can put a stent and prevent it from collapsing.
And many times we miss out with the diagnosis of the tracheomalacia. Means every tracheomalacia patient, when develops the tracheomalacia, many of the patients are not symptomatic. That's the reason we extubate. Patient is having good respiration, good tidal volume, will let him go. But still, many of the patients develop soft, moderate level of tracheomalacia that happens. But we are not doing in every patient the extubating over the scope. That's the reason many times we miss out the diagnosis of tracheomalacia. Asymptomatic.
So for us, like if a huge thyroid is there, the tube is kept next day, and then we extubate them on airway exchange catheters. And if doubt is there, then they are extubated on the fiber optic. So that's, I'm sure.
I will like to ask both ma'am and sir. Like, some of the cases with the huge thyroid and the surgeon says we want to check the vocal cord movement. So what is the ideal technique according to you, and what you have practiced, like on eye gel or like using a fiber optic, how it's done? Like,
Best way, if you extubate. Yes, Dr. Yes, Dr. Namarata, you get, then I'll be back. Okay. So best way to check the vocal cord is at the time of extubation. So you should have to extubate the patient over the fiber optic. So when you are removing it, you are directly looking at the cord. That is one. Second method, hyperangulated blade video laryngoscope. So you are not going to give the force when you are looking at it. And third, sonography.
Yeah. But in all these cases, when you're saying fiber optic and you keep the patient deep and then you extubate, otherwise the patient will try to bite and fight it.
See, yes. Another thing, in our routine is a protocol in our institute. All the patient we intubate, we are spraying the 0.5% bupivacaine intratrachely through the MAD device. So tolerance of the tube at the time of recovery is very good.
Very good.
So for us, it was from the beginning, a struggling patient putting the scope. I'm talking about 20, 25 years ago, to coming down to fiber optic and ultrasound. And most of it is consultant based also, because in an institute like ours, some would like to do sonography, some fiber optic, some would just do a gentle scopy and see. But
Gentle scopy and see.
yes. So I think the last question is for you, Dr. Apeksh, that minimal mouth opening that can allow video laryngoscope. Sometimes in irradiated neck patients, it is VLS sometimes difficult, gives good visualization, but negotiating tube is difficult.
Yeah. See, first thing, see that what video laryngoscope you are using, that is very important. So any cases, ideally you should use the hyperangulated bed or anatomically curved bed. So when you are using, suppose AMBU King Vision, non-channel valve, so antiopod, the width of that device is 13 mm. So with 13 to 14 mm of mouth opening, you can use that video laryngoscope. So you should have to decide according to the width of your video laryngoscope, which mouth opening will accommodate that video laryngoscope. And what was the next one?
That again, like if you even put the video laryngoscope, you get good visualization, but since there is no gap, you are not able to negotiate that tube.
Again, it's depend on the which type of video laryngoscope you are using. Suppose you are using the channel one. So common, the impingement happens at the right area epiglottic fold with the channel video laryngoscopy. So you have to withdraw the tube little bit, 1 to 2 centimeter, and make a 90-degree counterclockwise rotation of the tube inside the channel. That is how you can overcome this laryngeal impingement. And when you are using the hyperangulated video laryngoscope, specifically for nasotracheal intubation, again same maneuver. If it is impinging on the right area epiglottic fold, withdraw the tube and rotate 90 to 180 degree counterclockwise rotation. That will take the tube trajectory towards the larynx. Second thing, if it is going down into the esophagus, you can use the cuff impression technique. And still it is not going. Then you can have a little bit of flexion of the neck with the tubing. That will take the tubing. And the last resort is hybrid technique. Keep the tube inside, keep the scope inside, and pass a flexible endoscope through the tube with the video laryngoscope in situ, and take the tube scope out of that tube, go inside the larynx and over the fiber optics over the tube. So that's the hybrid.
This becomes totally for an onco anesthetist and people dealing with difficult airways. I would say for MD people, mouth opening is not restricted. Please do fiber optic.
Dr. Apeksh, how many video laryngoscopes you have in your theater?
So each one video laryngoscope for each OT. We are having 8 OTs.
No. I am asking, see, depending upon the mouth opening, you have to use the video laryngoscope, because we have a couple of video laryngoscopes. I am asking how many types of video laryngoscopes you have in your theater. Because
we are running a fellowship course in our advanced survey fellowship course. So we are having all type of video laryngoscope in our institute. That Macintosh, hyperangulated, J-step, video stilet, all type of video laryngoscope.
That's what I am asking. See how many laryngoscopes
everybody is that privileged.
how many laryngoscopes you purchase? So one fiber optic will do. And then I want to ask you one question. If you instill intratracheal bupivacaine, don't you think that when it admits the endotracheal tube, won't it allow aspiration pneumonitis because of this loss of sensation?
So because it's a highly absorbable solutions, so it will not lead to the aspiration. And many times, if you look at the bronchoscopy, when they are doing the bronchoscopic lavage, they are instilling almost 30 to 40 ml inside the larynx and suck it out. So 5 to 7 ml intratracheal bupivacaine is not going to make a harm to the patient.
It is not a harm. Because of this loss of sensation, I am asking. See, the idea of spraying the local anesthetic solution is to little bit the sensation is to be blunted so that the tracheal tube can be tolerated. Even you said the tracheal tolerance is very good with the spray. So when the tube itself tolerance is very good, won't it produce aspiration, because the patient will not cough?
See,
Because at the time of extubation, a lot of secretions will be there.
so this procedure has to be done only in a fasted patient, not for a patient with the food inside. That is one thing. And we keep all the patient in a high dependency unit for at least 6 to 8 hours. Then we are shifting the patient. And most of the head and neck onco cases we are extubating the patient on the next day, not on the same day.
That is okay.
That's the reason.
That is okay.
So that is why they require that even to tolerate that tube, sometimes we will not be connecting to ventilator. They will be just like a conduit for.
Yes,
So,
conduit.
so what sir does with puts the spray that they'll have a better tolerance of the tube. And by the time next day they are extubated, the effect is gone.
Important thing, what we are doing as an onco anesthetist should not be passed to each patient. Specifically, I'm telling this for the PGs. Because as an onco anesthetist, we are keeping the tube, we are keeping all the patient under observation, under our close observation for at least a day. When you are doing an individual based practice or shifting the patient to the ward, then this practice should not be done.
Yes.
So one jacket does not fit all.
Yes.
Straight jacket approach should not be followed. That is the take home message. Thanks.
And another take home message that onco anesthesia patients are very different. So
Yes.
we need to, how we are telling that our anesthesia, our management has to be really, really decided by that particular patient and where the tumor is. So that tumor can cause anything, can give you obstruction, can you give you that, if it's an airway, it can just, deform the whole thing, that you need to design your airway management for that particular case. Similarly, as for the surgeries, whether it's a lung surgery or it's a high pack or, so please add to it, Dr. Apeksh.
Yeah. See, for specifically for PGs or fresh pass out. So when you are handling such type of complex survey cases, you have to make your own protocol, your own algorithm, which is based on the resource availability with you, your technical expertise, your knowledge about the airway, and then you have to proceed. And you have to follow one of the algorithm, but you have to make it your own. If this is not going to happen, what will be the next? So that this planning should be made before you handle the airway. That's very important. And so once you start doing such thing from day one, from today, so after a year, you will be having a very good decision-making ability. So this exercise is very important to improve your decision-making ability when you are handling the complex airways.
Yes, sir, I agree. But whenever we are dealing or practicing anything, we should know if this doesn't work, what is going to be the next step that we have to do. We should always have a backup plan.
The mind.
So, Dr. Meenakshi, then I would, already we people get peripheral PGs, like all the MD students who come to Onco Institutes for, 15 days or 1 month, like Kidwai gets for 1 month or 15 days students. So I would now, you are the president-elect, I would say that it is a must for all the MD students to at least see these onco surgeries and or how they are managed. At least that should be done. And we just tell the students what you're doing here, but when you're alone, you cannot be practicing the same what you are doing in an institute like
Exactly.
so that is where what your place is, what your equipments are, what your expertise are, and who's there to help you. In an institute, if I have a problem, I have 10 people in the line standing for me. So we would end this webinar by telling that we wish that everybody is posted in institutes and they should see oncological surgeries and different surgeries, and they would be proud to see that as an anesthesiologist what more can be done.
We would be put up a recommendation to the university, madam, because it has to be included in the university curriculum.
It's there, sir. 15 days is a must count.
We will use our channel to force, because I have done it for radiology postings for this PCP and India Act. Only Tamil Nadu is the only state which has implemented postings, 1 month postings in radiology compulsory for anesthesiology postgraduates. but it is technically there. The chiefs may not send, but in the certificate it will be printed that they have done 1 month. So it has given the idea is good. We will take it up because they are sending it for neuro and cardiac and onco anesthesia. Routinely they are taking up in SGE cases only. Most of these onco surgeries are going on, surgical gastroenterology. So they are exposed, but we will make it as this thing at least 1 week. It is observer course for they
Especially
have
for
to visit
high back,
institutes.
robotic surgeries, liver, lung. It is
Yes, yes, yes.
for the students. That's what I feel.
Done.
Thank you. Thank you so
No
much, sir,
more questions,
for
madam?
giving all of us this opportunity. And I wish we would have more time and more discussion, but I know it's 8:05 and you had told me it should not go beyond.
Thank you very much, ma'am. Thank you very much.
Thank you.
Everybody was, even I have also not intervened because the discussion was good. Everybody was at their best. So that is the reason why I have not mentioned about the timing. I was also seeing the timings. Patients are also waiting for me. But I have to thank Dr. Shwetha for that fantastic presentation as a postgraduate and a consultant, and Dr. Pratishtha Yadav for the excellent details. Most questions are asked by me to initiate a discussion only so that the youngsters will be benefited. And as usual, if I say Dr.Apeksh Patwa has done very well, then it sounds no good. So it is as usual, he has to do that. It shows his expertise because he is living with the airway. So the expertise is projected. So I thank and Madam, the homely moderator we have ever had, Dr. Namarata ma'am. So I thank all of you and I request Clipnet to pass the concluding remarks to conclude the session.
Sure, sir. So, thank you so much to all the dignitaries present here. Client is really glad to have all these brilliant people together in session today, and I hope you all had a seamless experience. So, with everyone's permission, I am concluding the session in here for today and looking forward to host you again. Thank you so much, sir.
Thank you.
Thank you.
Thanks.